Hi, everyone, and welcome. We are Team 6, and today we will be presenting an analysis of prescription opioid policies. My name is Malcolm Smith Fraser, and on my team is also Wilson Huang and Dean Huang, no relation. So over the past 2 decades, the opioid crisis in the US has really been fueled by the overprescription of prescription pain medications. That has really led to a rapid increase in the number of opioid addicted citizens we have, and has also corresponded with a rise in drug overdose deaths. In the year 2018, there are roughly 2 million people in the country who had an opioid use disorder, and another 2 million people who misused prescription opioids for the first time. That same year, the country saw nearly 50,000 opioid-related drug overdoses. In response to this crisis, many state governments and local governments have begun experimenting with various policy interventions to restrict the flow of prescription opioids into their communities, with the overall hopes of reducing the overdose rates in their communities. In this analysis, we will look at 3 such policies. The first policy was a 2010 regulations implemented in Florida, which surrounded the registration of pain clinics, which are clinics that distributed opioid medications, as it prohibited the distribution of prescription opioids from physician offices, and also set up regional strike forces to help tackle the problem in various communities. The second policy we'll look at was a 2007 policy in Texas, which required in-depth evaluations of anyone applying to receive opioid treatments, and also required ongoing reviews of that treatment once it was approved. The third policy we'll look at were the 2012 prescription opioid regulations in Washington State, which required mandatory consultations for everyone seeking opioid prescriptions, and also required physicians to document the entire process of the treatment.
So the goal of our report is to analyze the effectiveness of policy on opioid shipment and overdose death. We're going to use 2 methods. The first method is called pre-post analysis, where we only look at the individual states and see the trend before policy implementation and after policy implementation. The next method we're going to use is called difference in difference analysis, where we pick 3 control states to control the national and regional factors and compare the trend before policy implementation and after policy implementation to make sure that the results are not due to the factors on the national level or regional levels. The data we're going to use for our study is DEA PAMPIO database, which provide the data on opioid shipment. The second database is US Vital Statistic, which provide statistic data on the third database we're going to use is US Census Bureau, which provides the population estimates, and we're going to use that to calculate the opioid shipment per capita and the overdose death per capita. In order to pick the ideal control states for our states of interest, we're going to look at political similarity, geographic similarity, and demographic similarity. So the policy implementation year for Florida is 2010, and the control states we pick for Florida are South Carolina, Louisiana, and Mississippi. As you can see from the pre-post opioid shipments, the pre-post graph for opioid shipment in Florida shows that before the policy implementation, there's a increase of morphine per cap for Florida. However, after the policy implementation, there's an abrupt decrease of opioid shipment for Florida. In order to form a more concrete conclusion on the effects of a policy, we're going to look at the difference in difference graph next. As you can see from the difference in difference graph, before the policy implementation, both Florida and its control states exhibit an upward trend. However, after the policy implementation, only Florida exhibited a downward trend, while the control states continue to exhibit an upward trend. Therefore, we can conclude based on the graph, the policy is effective in terms of reducing the morphine per cap in Florida. Next, we're going to look at the overdose deaths for Florida. As you can see from the graph, before the policy implementation, there's a slight decrease of overdose death per capita. And after the policy implementation, even though like the graph is still decreasing, however, it decreased at a faster rate. Next, we're going to look at the difference in difference graph for Florida. So before the policy implementation, the nearby states exhibit an upward trend while Florida exhibited a downward trend. After the policy change, as you can see from the graph, the nearby states continue to exhibit an upward trend while Florida exhibit a downward trend. However, since before the policy implementation, Florida also exhibited a downward trend for overdose death per capita. Therefore, we can draw a solid conclusion on the effectiveness of policy on the overdose death per capita. This is a brief summary of our report for Florida. As you can see, the policy is indeed effective in reducing the opioid shipments. However, there's no clear evidence showing that the policy is effective in reducing the overdose deaths due to the same downward trend before the policy implementation and after the policy implementation.
The second policy that we're going to look at today is the 2007 opioid regulations in Texas. The control states that we look into are New Mexico, Kansas, and Arkansas. When looking at the initial pre-post graph for opioid shipments in Texas, we can see that before the 2007 policy was implemented, the per capita volume of opioids imported into Texas was increasing steadily. This trend stayed consistent even after the policy change. However, we can see that in the first year, between year 0 and 1, there appears to be a significant spike in the volume of opioids shipped. Again, we cannot blame this spike on the policy itself. To do that, we need to compare with other regional factors, which we do with the difference in difference plot. In the difference plot, we see that prior to the 2007 policy, both Texas and its control states exhibited an upward trend in the per capita volume of opioids imported. Again, after the policy implementation in 2007, both states exhibited a similar trend as they had before the policy was implemented, and both states also saw a spike within that first year of the policy being implemented. Again, from these results, we can say that there does not appear to be any significant effect of the policy implementation in Texas. Next, when looking at the pre-post analysis for overdose deaths in Texas, we can see that prior to the 2007 policy, Texas saw a slight decrease annually in its per capita overdose deaths. This trend continued to decrease and actually decreased at a slightly faster rate after the policy was implemented. However, we cannot say that the policy was effective in reducing that slope, as we need to compare with other with the control, as we do the difference in difference, and also our standard errors are very wide, and thus such a slight decrease may just be random. When looking at the difference in difference plot for overdose deaths between Texas and its nearby control states, we can see that while both contexts of control or Texas exhibited opposite trends, both before and after the policy was implemented, the trends before the policy was implemented in Texas was the same as the trend after the policy implemented in Texas, and the trends before in the control states was also the same as the trend after. As such, we can say that there does not appear to be a significant effect of the policy implementation in Texas or anywhere else that may have influenced overdose deaths. To summarize, the 2007 opioid regulations in Texas do not appear to have had any significant effect on the volume of opioid shipments imported into Texas or on the overall per capita number of overdose deaths in Texas.
Now let's look at the policy in Washington in 2012. The three control states we picked are California, Oregon, and Colorado. According to the pre-post analysis on opioid shipments, Washington is displaying an upward trending in opioid shipment, although such trend maintained after the policy change. There is a sharp decrease in the shipment volume after the policy. In order to generate a more solid conclusion, we compare the results with the other control states. According to the difference in difference analysis, Washington and its control states are displaying similar trends before the policy change, increasing, while such trend remains after the policy change. There's a sharp decrease in shipment volume in Washington, while a sharp increase in shipment volume in control states. Therefore, briefly speaking, the policy implemented in Washington is effectively reducing opioid shipments. Now let's look at the overdose death statistics. According to the pre-post analysis, overdose deaths in Washington is slightly decreasing before the policy change, but remains constant after the policy change. In order to generate a more solid conclusion, we compare this result with the other control states. According to the difference in difference analysis, Washington and its nearby control states are displaying opposite trends in overdose death before the policy change, and such trend remains after the policy change. And note that the gap between these two groups after the policy change grows larger. Therefore, briefly speaking, we can safely conclude that there is little impact that this policy due to overdose death in Washington. In general, through the analysis above, we conclude that the policy implemented in Washington, D.C. in 2012 has effectively reduced opioid shipments, while has little impact on the volume of overdose death. Now, to sum up, for opioid shipments in Texas and Washington, while there's limited data to generate concrete evidence, the policies do appear to reduce the per capita volume imported. And none of the three policies appear to have any effect on the per capita volume of overdose death. However, the standard error is too large to draw solid causal inference. And we also put together two aspects that can explain why the policy in Florida yields much better results than it does in the other two states, probably due to the notorious fame that Florida already gained in large amount of drug prescriptions and former failure in controlling. The policy in Florida in 2010 contains a series of regulations and compulsory commitment. There's even a special task force established to deal with the prescription abuse. In contrast, the policies in Texas and Washington are one-time, and there's no follow-up policies or institutions to oversee the enactment. Also, some of the guidelines are recommendations, which is not compulsory for doctors and medical institutions to comply with. Therefore, the different results that those policies yielded in different states are understandable and foreseeable. The other aspect is chain of effect. In general, the enactment of opioid drugs-related policies appear to be effective in decreasing the volume of opioid shipments. Ideally, as a result, the consumption of opioid drugs ought to decrease and hence affect the overdose death statistics. However, this chain of effects may not be entirely true. to explain why. There might be potential confounders like mental health aspects of addiction. Also, people are less likely to accidentally overdose in prescription opioids than illegal ones because of the regulated chemical formula. In addition, these policies are only restricting the flow of prescription opioids. As a result, addicts might purchase illegal opioids like heroin, fentanyl instead. We appreciate it if you can hit the subscription button below, and your support is our greatest motivation to create new videos during this pandemic period. Wear a mask and take care. Thanks for watching.
Thanks for watching.
Thank you.